We will have the question and answer option enabled in the webinar, so you can feel free to use that throughout, and know that those questions will only be visible to us, the event organizers. Our previous talks have focused on the use of immunotherapy and on Logic, our diagnostic tool. And so while the consortium looks at both somatic and inherited replication repair, today's webinar is focused on surveillance for CMMRD. CMMRD is the biallelic loss of mismatch repair deficiency, and it is an inherited germline condition. Patients with this disease are predisposed to cancer, and surveillance is the idea of following the patients over time and ensuring that they undergo regular imaging, scoping, testing to identify early signs of tumors for early intervention. Ayse will present to you her evidence-based benefits of diagnosis and surveillance, and then Liana will demonstrate a new and highly effective method of monitoring CMMRD patients for cancer. After each talk, we'll have time for a couple of audience questions. So again, please use that Q&A feature. And then later on, we're going to have our panel discussion. You can see our panelists here along the bottom of the screen. And we'll be focusing then on some pre-submitted survey questions, thanks to all of you. My colleague Vanessa will be taking over and introducing them at that time. You can always reach out to us at the email address that's shown here on screen, replication.repair@sickkids.ca, to let us know what you may have enjoyed or you may want us to touch on more in future events as well as in our newsletters. So with all of that, I'm excited to first introduce to you our first speaker. This is Ayse Ercan, and Ayse is a master's student at the University of Toronto. She's been under the supervision of our lead, Dr. Uri Tabori, for several years now. And she played a pivotal role in the publication of our manuscript looking at the benefit of surveillance and the surveillance protocol for patients with confirmed or highly suspected diagnosis of CMMRD. And I know that that publication and its use has been incredibly impactful in terms of the well-being and survivorship of our patients. Now her focus has been on taking all of the clinical and biological information that we've collected as a consortium, all of this, and identifying significant relationships and insights on the manifestations of CMMRD in our patients. So with that, Ayse, please take it away.
All right, thanks, Lucy. Let me share. Okay. Can everyone see my screen? Okay.
Looks
great.
good.
Okay, great. Okay, so hi everyone, my name is Ayse. I'm a graduate student in the Tabori lab, and as Lucy mentioned in our intro, our international consortium has grown to include many patients, families, collaborators all over the world, and using the data that we've collected with your help over the years, we can now understand more about what CMMRD is and to help patients all around the world. And these are some of our findings. So today I'm going to be talking to you a little bit, I'm going to be talking to you about CMMRD. So those are the patients that have inherited biallelic mutations in mismatch repair, meaning that they've inherited 2 copies of mutations in mismatch repair. These patients do not have functional mismatch repair, so that they're at risk of developing different cancers. These are the 4 genes that lead to CMMRD, and they're listed here. And although that these are the 3 main cancer types, around a year or 2 ago, we showed that the spectrum of tumors is greater than what we had previously thought. So with your help and with over 200 patients with CMMRD, we're able to get some more insights on this syndrome, which is helping us with the treatment and management of patients. So despite what we know about CMMRD, there are still some unanswered questions that we want to answer. So for example, what is the contribution of family history in CMMRD? What are the important clinical manifestations? We often see CMMRD patients are initially thought to have a different syndrome called neurofibromatosis 1 based on some of the skin manifestations. And you can see an example of how similar they look. So this is an adult NF1 patient, and this is a CMMRD patient, and you can see how similar the skin features look between the two. So we wanted to see how similar or how different the two syndromes are. And remember, I mentioned the 4 genes in the previous slide. Some of the other questions we're interested in is there a difference in how patients present depending on what gene is impacted? This is called genotype phenotype. And lastly, what else can we learn about these cancers? So these are our methods. I'm not going to go into too much detail here, but the main thing that I really want to emphasize is that we have 201 patients that are confirmed CMMRD using established diagnostic criteria. We have tons of data on these patients, and notice the striking number of tumors that we have from these 201 patients in the study. So as expected in an autosomal recessive syndrome, consanguinity is also high in CMMRD. Interestingly, though, we found that most of our CMMRD patients are in countries where consanguinity is not common. Here we labeled it as low. This next figure basically highlights the same point, but using sort of a more biological way. It uses the germline mutation of the patient in our study, which is called germline zygosity here. But the main question of these two is, why do we have so many CMMRD patients that live in countries where consanguinity is not common? So we looked a little bit deeper into this, and we found that it isn't always necessarily consanguinity between family. It can happen in small minorities or communities that are isolated. For example, Newfoundland, Canada. It's important that we look in these specific communities because it can be enriched for autosomal recessive syndromes like CMMRD. And we think that these findings are important because it allows doctors in these low prevalence countries to think about CMMRD when they might previously not have. And earlier reports of small number of patients suggested that CMMRD patients do not have a family history of cancer. And when I looked a little bit deeper into this, we found that a majority of CMMRD patients actually do have a family history of cancer. However, here we don't see this history of cancer in the parents of CMMRD patients. Learning this, we believe it's important to go deeper into the family history, which can help us determine if extended family members have developed cancer or if they might be at risk of developing cancer, which in that case, we would want to implement surveillance early on. And oftentimes we see that CMMRD patients are initially misdiagnosed as NF1. So we wanted to look at how prevalent these overlapping skin manifestations were. Using these overlapping skin features, we found that almost 1/3 of CMMRD patients fulfill the diagnostic criteria of NF1 in the absence of germline testing. And this suggests to us that we need to use functional or molecular tools for diagnosis to try and avoid a misdiagnosis of CMMRD. Looking at these blue arrows over here, previous publications suggested that CMMRD patients have intellectual disability or autoimmune symptoms, so we wanted to investigate that in a larger cohort. And we're happy to report that although it may happen in some patients, it's not as frequent as we previously thought. So now that we have insights on CMMRD patients, we want to move on to their tumors. Remember, we have 339 tumors, which you can see right here. First, we see that this cohort has the 3 main cancer types, which I showed you earlier, most common being the central nervous system cancers and gastrointestinal cancers. We also have this 4th group called other, where we can see a variety of other cancer types that we wouldn't have expected, such as prostate cancer in older ages. And even in the cancer types that are known, like hematological cancers, we can see such diversity in the subtypes that we never thought we would see these in CMMRD. And this tells us that really anything can happen in CMMRD, and it just justifies the importance of the surveillance protocol. So now that we've established the spectrum of cancers, we wanted to get into some insights on genotype phenotype. So remember I said that there were 4 genes. Here we want to see, are there differences in the cancer types based on the germline gene that is affected? And the main thing that we notice here is that hematological cancers, so those are the orange ones here, they are very common in MSH6 and PMS2, but almost not almost do not exist in MLH1 and MSH2. There's very, very few of them. And we think that this might be due to the nature of these mutations based on the biological role that MSH2 and MLH1 play in the cells. So this, in this graph, you can see the age across the bottom here in years, and these are each of the cancer types across here. So using the 339 tumors, we wanted to look at what age do these tumors develop. And you can see that there's a difference in the age of diagnosis for each cancer type. This helps us know which cancers to look for at specific ages and to better optimize surveillance protocols in the future. So this is another example of genotype-phenotype, and here we wanted to see, are there differences in the age of diagnosis depending on the germline gene that's affected? On the bottom is the germline gene, and you can also see that here it's based on the color, and across here is the age, and it starts at 0 over here. And we did this for our 2 main cancer types. So this is all central nervous system cancers, and the second graph is gastrointestinal cancers. And we can see that MLH1 and MSH2 occur at a younger age of diagnosis for both central nervous system and gastrointestinal cancers, suggesting that the biology does matter. So these are called Kaplan-Meier curves, and the bottom shows the time in years, and each curve is a different group. So this is what we have today, and I want everyone to keep in mind that this includes some older patients that are in our consortium before we knew much about CMMRD or had interventions like surveillance and immunotherapy. But as expected, our central nervous system tumors and hematological cancers are doing worse, but with immunotherapy and surveillance, we think that this curve is going to improve over time. And looking at the genotype-phenotype, although MLH1 and MSH2 have a greater impact, with surveillance, we think that this can improve over time as well. Overall, we found that cancer type and genotype are important for outcome, but we are improving the outcomes by doing surveillance and immunotherapy, which you can see here for surveillance, where patients on surveillance show improvement in MLH1 and MSH2 especially. And we believe that surveillance can alleviate the differences of genotype, which is why it's so important to implement it early on in CMMRD. And similarly, in immunotherapy, we can see a great improvement in outcome, which is this curve over here, when immune checkpoint inhibitors are used effectively. So our take-home messages are that only with a large data set and the help of all of our patients and families and collaborators were we able to talk to you today about some of our insights on CMMRD. Large data sets like this can help better inform standards on diagnosis, frequency of surveillance, treatment, etc. And since family history and scan manifestations are non-specific, global diagnostic tools are important for CMMRD diagnosis. Age of tumor onset and genotype-phenotype may affect future surveillance protocols, and ongoing surveillance and immunotherapy changes outcomes and may change the landscape of CMMRD. Thank you all for listening, and thank you to all of our amazing patients and families and collaborators. If you guys have any questions, please feel free to contact us as well in these email addresses. Thanks again, and I'm happy to answer any questions.
Thanks, Ayse. There was just one question, and I think you'll be able to answer it pretty easily. The question was, can CMMRD also be caused by biallelic EpCAM mutations?
So that is a great question. EpCAM is interesting because right now we only see it affecting certain tissues, specifically the gastrointestinal tissues, just based on where it is in our DNA. It can cause CMMRD, but it's a little bit more complicated in how it happens. We believe it's through a process called methylation. So it can cause it, but it's a little bit different, I would say. Yeah.
Thanks.
No problem.
All right. So we'll move on to our next speaker then to keep to our schedule. So our next keynote talk will be coming from Dr. Liana Nobre, who you can see on your screen. Hi, Liana. Liana is a physician scientist here at the Hospital for Sick Children in Toronto, Canada. And Liana works closely with Dr. Cynthia Hawkins, who is a world-renowned neuropathologist, also at the Hospital for Sick Children. And she also oversees all the pathology consults that we receive through the consortium. So Liana's focus has been on molecular diagnostics and the development of treatment monitoring tools. She's developed things called nanostring RNA panels that are used to assess specific pathway activations or mutations in high-grade and low-grade gliomas. And today she'll be talking to us about the use of cerebral spinal fluid to monitor cancers over time via screening for something called circulating tumor DNA. So thanks so much, and Liana, take it away.
Thank you so much. It's a pleasure to be here and speaking to everyone about some of the work that we've been developing. So let me just share my slides. Okay. And can everyone see that? Yeah, okay, good. So I want to start by introducing everyone to the Hawkins Translational Lab, led by Dr. Cynthia Hawkins. And in this lab, our whole purpose is to develop tools that will guide us and help us into diagnosing patients, determining prognosis of tumors, and helping guide therapy. With this, we've developed, as Lucy mentioned, a series of platforms and tools that are already clinically approved and in current use. And we have a few tools that I've specifically worked on over the last few years that are under development and into the track of being clinically approved and implemented. And today I'm going to focus on the liquid biopsy and the strategies that we have been developing within the liquid biopsy scope. And the main reason that we're interested in these tools is that we do believe that a liquid biopsy will soon replace surgical biopsy in a lot of the instances in patients' settings that we have. And it will also be used to add information throughout the patient's treatment journey. So I will talk a little bit about that more in depth. So I'd like to start by defining what is liquid biopsy. So liquid biopsy is the process of acquiring through minimally invasive procedures, liquid sources that we have in our body to look for specific alterations or molecules that can guide and can tell us something about a disease process. In this case, what we're looking for are alterations that would be present in a cancer cell and that we can find in easily accessible tumors without having to do a surgical biopsy. Largely used, especially in the adult world, is blood. We can access urine, cerebrospinal fluid, and saliva or stool. I'm going to concentrate a little bit on this talk in brain tumors. And for brain tumors specifically, the source and the fluid that we found to be more sensitive is the cerebrospinal fluid. And this is the fluid that bathes our brain and spine. And it's in closer proximity to the lesions that are present in the central nervous system. Within these liquids, we can find a series of molecules or analytes that can be studied. I'm today going to focus on cell-free DNA, and cell-free DNA are really small fragments of DNA that all of our cells are shedding into these fluids, and we can find them from normal cells to diseased cells such as cancer cells. And what we're interested in really is to find alterations that are present in these tumor cells and that we can find in these small pieces of tumor DNA and that are not present in our regular body cells. One of the things that we're going to touch upon is that the proportion of tumor DNA that is present, or cell-free tumor DNA that is present in these fluids, is very, very small compared to the proportion of normal cell-free DNA that is present in these fluids. So I'll touch upon some of the challenges and things that we need to think about when we're considering liquid biopsy, specifically in pediatric brain tumors. So one of the things I've already mentioned is the small proportion of this analyte, the cell-free tumor DNA that we're looking for. The other one is the choice of fluid. So for our brain tumor patients, we would at this stage look for cerebrospinal fluid versus blood, as the sensitivity is still higher in those. Another thing that we need to think about is the source and the volume. So the way we obtain cerebrospinal fluid is usually through a lumbar puncture, or if at the time of surgery or a surgical procedure where patients need an insertion of a shunt, we could obtain the fluid that way as well. Another thing that impacts the sensitivity of these assays is the site where the tumor is located. So if it's more proximal to where our cerebrospinal fluid is located, we tend to have a higher sensitivity, and that will depend as well on the amount of disease that we find and the stage of the disease. All of that will factor into us choosing what type of test we're going to do to characterize these cell-free tumor DNA. And how can we use liquid biopsy? So one of the big things that we can do is at the stage of diagnosis and surveillance. So in specific to the scenario of MMRD patients, we're able to follow patients and use these strategies for early detection and diagnosis of brain tumors. With that diagnosis and detecting molecular alterations that are pertinent to the tumor, we can sometimes find mutations that have targeted therapies, that have drugs that are specific to those molecular alterations. So we can implement personalized therapy as well. Additionally, we can use this strategy to monitor patients. So patients that are undergoing therapy, such as immunotherapy, we can monitor over time and collect these samples over time and detect the quantity of that alteration in these fluids. And what we want to see is that over time with treatment, those levels are going down. And if there's by any chance a recurrence, we pick them up going back up. Another thing that we can do is find new alterations that with the tumor evolution may appear and may help us in guiding therapy and even adding additional agents. Finally, we can detect very, very small quantities of these alterations, which may allow us to detect an early relapse and quantify minimal residual disease, permitting us to change treatments in case this does happen before imaging detects a potential recurrence. There's many methods and many tools that we can use to analyze these alterations. I'm going to focus today on the two that we are developing currently, which are next generation sequencing, and specifically a panel and low-pass whole genome sequencing. So when we talk about panel sequencing, what we do is we collect the cerebrospinal fluid, we extract the DNA, we make libraries for next generation sequencing. And then what we do is with the panel sequencing, we have a selection of genes that are commonly mutated, and we sequence those genes very, very deep. We look at them many times, and we're able to detect small point mutations and fusions in those specific genes that are in our panel. Another strategy that we use with the same libraries that we have made is we tile and we look at the whole genome at a very shallow depth, so between 1 and 3 times. And that does not allow us to look for these more point mutations and specific mutations, but it does allow us to find large deletions or gains in the genome. So these are two strategies that we can use to detect alterations that are pertinent to the tumor. And what we've done is we've validated these panels in a retrospective cohort of brain tumors and different types of brain tumors. And what I want to show you today is that for specifically high-grade gliomas in MMRD patients, the sensitivity was really high, with 83% of them being positive. So this allows us really to implement these tools in all of those stages that we talked about. And I want to finalize by presenting a few current cases where we think this strategy was useful and how we envision using this moving forward. So on a first case, this is a teenage patient that had a diagnosis of high-grade glioma with an IDH1 and P53 mutation in the tumor. We found the same mutations present in the CSF with the addition of a PIK3CA mutation and some variants of unknown significance in other MAP kinase genes. So for this patient who is currently on treatment with immunotherapy, we can potentially envision using these results to, if necessary, add additional targeted agents. Additionally, from the same sample, we were able to profile the copy number alterations that are present in this sample and compare to what are present in the tumor as well. And this can be used over time to assess the stage of the tumor, whether once it's not picked up in imaging anymore, we are able to still detect it on the liquid biopsy. Another example of a patient diagnosed with MMRD high-grade glioma, and this patient at the start of immunotherapy had mutations in FGFR3 and P53 present in the CSF, which were also present in his tumor at diagnosis, and we could also find copy number alterations in these tumor. 4 months later, he had a picture with neurological deterioration, and really the imaging wasn't successful in showing us whether this was due to toxicity to the drug or if there was progression in the lesion. So the CSF helped us confirm that there was still tumor there and mutations found, as well as the copy number alterations that were pertinent to the tumor, helping us decide how to move forward with this patient's treatment. And in this last case that I want to show you, another high-grade glioma patient with mutations that were present in the tumor confirmed in the CSF with also alterations in the copy number profile. For this patient, we additionally are starting to implement our logic tool, which Lucy mentioned briefly in the beginning. And the logic tool can identify a score which will predict MMRD, basically. And we've used this for previously in tumor tissues, and now we're currently developing it so that we're able to detect these levels in the liquid biopsy as well. And here what I'm showing is the red dot is this patient sample compared to tumor MMRD positive controls. And here the 3 green dots are CSF samples from MMR proficient patients that are negative. So to summarize, the way we see using this tool in the MMRD patients is at diagnosis, to be able to detect these alterations, and then throughout the patient's treatment journey, monitor response to therapy, potentially help decide whether it's the time to finish therapy, and then follow up thereafter to be able to detect early recurrences. So I want to thank all of the patients, the collaborators, the Tabori lab, and the Hawkins lab, and specifically the team that works directly with this project. Thank you. And I'm open for questions.
Thank you, Liana. That was amazing. We had a few questions, but they all kind of come to the same root, which is asking, as a parent or as a family member, is liquid biopsy already being implemented in clinic as part of the surveillance protocol as a standard of care? Or is this something that parents themselves or healthcare teams or we as a consortium need to still advocate for?
So at this stage, we have started using this on a research basis, and it is quickly being transitioned. So we're at the stage of implementing and transitioning it into clinic, which means it's been validated, and now we are in the process of implementing it clinically. It is available through the consortia on a case-by-case basis, through the case discussions, and Uri and Anirban have been connecting our team with the interested physicians and how to enroll these patients basically and get this done.
I just want to add to that, if that's okay, Lucy, that this is one of the reasons to give you updates is that Liana and Cynthia have now the ability to do some of these things, but the only way to see if it's actually helpful is to together collect this information longitudinally. So for many patients to follow over time, take blood tests and sometimes CSF, and that's we do on a patient-by-patient basis to see if it can actually predict something to happen or actually predict surveillance and other things. So we really want your help in getting this information so we can maybe in 1 or 2 years say, wow, that was really helpful for surveillance, very helpful for targeted therapy, and maybe not as much to monitor response. So this is why we present, because you need your help.
Thanks, Ari. And I just want to also add, there was a question asking pretty much the same thing, but with regard to cost. And I just want to say that as a consortium, we do receive research funding for this purpose. And so any collaborations that we do with local healthcare teams very often fall on the bill of the consortium. And so the benefit to working with us is that we're able to do a lot of these things free of charge to you. So I just want to circle back to Ayse. There was a question that came in, sorry, just after we switched to Liana. It's always a little bit of a delay. And it was a similar question to the EpCAM situation, but asking about polymerase epsilon and polymerase delta, or POLE, POLD, and whether those qualify as CMMRD as well.
Yeah, so thank you for that question. That's a great question. So there's kind of 2 points I want to make. So there is a separate syndrome called polymerase proofreading associated polyposis, which is caused by polymerase mutations in the germline. These patients are included in our consortium under replication repair deficiency. They present a little bit differently than CMMRD, and we don't have quite as much knowledge or information about them. So we're still investigating the genotype, phenotype for these patients and learning a lot more about them as we get patients enrolled. We do have some patients with CMMRD where their tumor can actually get a polymerase mutation, and these patients' tumors look a little bit different, and they tend to respond well to immunotherapy. Dr. Das is kind of our expert on that. So yeah, so that's kind of the 2 aspects. You can have it in the germline, which is a separate syndrome, or you can kind of have it in the tumor of a CMMRD patient, and they're kind of treated both differently.
And again, I want to add to that is that the beauty of this consortium that it's not only for CMMRD or Lynch patient or polymerase proofreading patients, it's for all the tumors that people have, including if it's nothing in the germline. Right. And we help with monitoring that. And just to get people excited, actually the signature of polymerase is actually much stronger than mismatch repair to detect in CSF and in blood. So if you have patients or you are patients that you want to join us and monitor that, we believe that is going to be very, very feasible.
Yes, Liana, just one more question. So someone was asking about liquid biopsy, but more in the context of gastrointestinal cancers, polyps, tumors. Is that something that you're working towards, or what's feasible right now?
So at this stage, we've mainly been working with brain tumors, but there's a large body of work with colon and other non-brain tumor cancers, and really it's much easier even to detect using blood, right? So a less invasive procedure than what we need for our brain tumor patients.
Thank you. So with that, I will hand it over to Vanessa and we'll start our panel.
Okay, perfect. Thank you, Lucy. Hi everyone. If you don't know me, my name is Vanessa Bianchi, and I'm the program manager for the IRRDC, and I'm going to lead the panel today. We have a very diverse group with us here today, and I'm excited to present them all to you. Maybe you guys can all give a little wave when I introduce you. So I'm going to start off with Dr. Uri Tabori. He is a pediatric oncologist and senior scientist at the Hospital for Sick Children. And he is the leader of the consortium. Dr. Anirban Das is a pediatric oncology fellow and geneticist who co-leads the consortium with Dr. Tabori. Parvati Krishnan is a patient advocate, a RRD parent, and the founder of the Krishnan Family Foundation. Bailey Gallinger is a genetic counselor at the Hospital for Sick Children, and she has experience diagnosing and counseling RRD patients and families. We have Dr. Van An with us, who is a pediatric neuro-oncologist and scientist at Cancer Care Manitoba, as well as an assistant professor at the University of Manitoba. And we have finally with us Angela Johan, who is a social worker at the Hospital for Sick Children. She has firsthand experience working with and counseling RRD patients and families. So thank you all for joining us. We had sent around a survey previously to get some questions from the audience, and we got some really good, again, very diverse questions. So I'm going to start off with one of the first ones that we saw, which was, who should parents of children with CMMRD have on their team? Parvati, do you maybe want to take that one?
Yeah, I'll take that one. So there's two parts to this. If your child has a cancer and the diagnosis is cancer, the oncology and the team, whoever you're seeing is the primary team. I believe from our experience and from interacting with everybody in the consortium, the team, the oncologist team is the one that will be talking with the sick kids team. So I do think that the consortium being involved is extremely important, but I think from my perspective, it will be best to go with the team that is working to fix the cancer that the patient has. In addition to that, from our experience, we travel far to get treatment for our son. And so it's extremely important for us to also have a robust local team that will help us in terms of emergencies, or even if we have any questions or concerns or everything else that cannot be done that is related to treatments. In our case, we are fortunate that we have a fantastic complex care team. I now know that not many hospitals have that across North America or across the US where we live. But if you do have a complex care team, I would highly recommend that families reach out to them to have their child be a part of that team, because they are thinking whole body. They're not just thinking cancer. They're just not thinking genetic predisposition. They're actually trying to help you figure out everything else that the specialists cannot help you with. So having them on your team is extremely helpful, not just for the person you're caring for with CMMRD, but also for the family and the parents and everybody else. And lastly, we are big proponents of palliative care in our family. And so palliative care, pediatric palliative care at least, does not mean death or anything that we would normally associate with adult palliative care. So if you do have that team, they can provide a lot of resources and support that other teams cannot. So for me, these are the big teams that have usually helped us a lot. And they also help us coordinate both with the consortium and with all the active medical teams that we have going.
Thank you, Parvati. I love the idea of a home team and having that support here as well. I think it's really, really important to have that in the home and not just, outside or wherever you're being treated. So thank you for those suggestions. I do want this to be more of a discussion. So even if I ask one person to answer, please feel free to jump in if you have anything to add, or, if you want to say anything else, please feel free to jump in. The next question I'm going to ask is, what tips do you have for someone who, or for a parent or family or patient who was maybe just diagnosed with CMMRD recently? Angela, do you maybe want to start this? Parvati, you can definitely jump in.
Sure. Thanks, Vanessa. So I all of the patients and families who are here, I would say that you are already steps ahead by joining this platform. To say that CMMRD journey is an extraordinary one would be to put it lightly. And I would agree that staying engaged with your healthcare providers and specialists is key to accessing that niche support. So my advice would be to, ask questions, source information directly from your teams, to make well-informed decisions, connect with a staff member on the primary team to direct your questions to. I would say keep a journal to write down all of your relevant notes and questions. Having a binder to safekeep the written materials provided to you is really helpful. And I would say it's beneficial, especially in the beginning, where you are expected to parse out really complex medical information at a time that's emotionally difficult for families. And so having a simple but systematic way to store information can feel immediately relieving and worthwhile in the long run. I would also ask to identify who on your medical team or community is available to talk through and find resources for financial, legal, practical, and other issues related to medical care where relevant. And then also to connect with psychosocial team members who may be able to identify the same or further resources to manage some of the impact to daily routine, school, employment, family dynamics, and so on. And I would say that it's really important to pay close attention to your needs above all, particularly the basic ones like proper rest and nutrition. It helps to identify the person or people in your life who can offer help managing the competing demands of medical care and personal life. And, finally, I would say seek emotion-focused support where you feel it might be helpful, either through loved ones or professionals, or connecting with others who have shared experiences, like the families who are here. And all of this is, of course, to say that it comes down to what your individual needs are and honing in on the supports available to meet them.
Maybe Bailey, you can tell us. So you're the one who diagnoses with us and other people and then meet the family. What would you suggest? What are the tips for them that you usually do?
It's a good question. I think that reminding everyone that it's a process, so we're not going to get all the information out in one session. So for new diagnoses, it's obviously very overwhelming and there's so many implications, not only for the patient that's been diagnosed, but of course the family, as we know, specifically with CMMRD, the parents are getting a diagnosis of Lynch syndrome themselves. So I think it's important to remind these families that it's okay for this to take a long time. It's a process. It's going to happen slowly. But similar to what Angela said, making sure you have all your support systems in place, reaching out to the right people, and just being really, I would say, kind to yourself, especially at the beginning. There's a lot of guilt and emotion. So just taking it step by step has been helpful for families at the time of diagnosis.
I think one of the most overwhelming emotions we had was isolation. Like, oh my God, where do we go? What do we do? Fortunately, there's a very, I would say, quite an active Facebook group that we do have. It's not supported by the hospital or anything like that, so full disclosure there. But it's a group of, it's as safe space as it can be on a social media platform, but it has bereaved parents, it has parents with children who have never had cancer with CMMRD. We've had parents who have had multiple cancers. We've had parents from all over the world, adult patients, and we've had such amazing discussions. We also do like a call every couple of months where whoever can joins, and we all just chit chat about life. And we may have questions. None of us are doctors, none of us are physicians. So we know coming into that it is just a safe space for us to talk about whatever it is we want to talk. There's no agenda. For me, that's been extremely rewarding because it feels like even though in this big world, it's my child has this one condition, when we get to talk with everyone else, it feels like, okay, there's someone somewhere who at least relates to what we're talking. And so most of what I always say is that it does feel isolating, but it can be better. When you reach out to others, you may not want to talk. If you want to talk, it's up to you. There's no one you don't have to participate if you don't want to, but we are there. So I know Vanessa has a link if someone wants to reach out to us. If you're in the medical field and you're coming across patients who are having this condition or families, please let them know as well that they can reach out to us via the Facebook group, because we're here for them as well.
Maybe last thing to add is that the world is a village today, so you can reach out to anybody very easily. So please do that. And the best advocate for yourself is yourself. So don't be afraid to reach out. Just a quick thing about how we work, the consortium, that we have 50 countries, but we work with the healthcare providers, as Parvati said, and with the families. So for us, if it's just a genetic diagnosis and questions of CMRD, Lynch, PPE, and others, we take our time, we work with Bailey, we work with the physicians, we work with Angela, we work with you, Parvati, and sending them support to see slowly what it means. But once there's cancer involved, it's a very different approach. We work very fast. We need the doctors. We work with Vanan and other doctors very fast. And that's a very different approach that we do according to the situation. So just be your own advocate and involve us soon.
Thank you, Ayse. Those were some great suggestions and insights. So thank you all for contributing to that question from the audience. It was a really important one, I think. The next question that we have is sort of along the lines of, all right, so now you're diagnosed with CMMRD. Maybe now you need to choose a therapy, a surveillance regimen. What information do you need to perhaps choose the best therapy for a child or a patient that is newly diagnosed with cancer or just newly diagnosed with one of these syndromes like CMMRD?
Yeah, so I can take that, Vanessa. In fact, thank you everyone for joining this seminar. I think it's a very, very important question. The first thing I always want to say is that when you say what is the information you need to gather, this could be in a very couple of different situations. It could be for the first time you're getting diagnosed. And it also depends on actually which tumor you're talking about. It could be in the brain, it could be in the intestine, or it could be in the blood. So the different types of cancers. Also, it could be that you already have been diagnosed and then things have actually come back. And then at that time, what you're looking for. So generally what we do at this time is when we actually suspect a patient with, let's say, BMMRD. So the first thing we ask the pathologist is that when he or she processes the tumor, look for actually the 4 important proteins, which actually Ayse actually showed in her slides. Look for them in the tumor tissue as well as the adjacent normal tissue. That's what we actually ask for. Now, in my opinion, I think Uri will actually second this. Probably it should become a routine for screening almost every cancer that we actually go through in children. But I think we are still not there yet. But at least in a patient who has these so-called suspicious clinical features, like what Ayse showed you, in fact, all these Kappa-Elia macules, if there's consanguinity, if there is history of actually certain specific type of cancers, okay, or if there is a strong family history of cancer, in those patients, yes, there is extremely important that you try to actually screen for these 4 proteins in the tumor tissue and the adjacent tissue. That's the first step. Now, once you actually make a diagnosis, then subsequently, now you have implications to go dig deep into actually the diagnosis, because now you have to actually sequence the tumor, see what type of defect is there. Because again, Ayse showed you very well that there is actually a genotype-phenotype correlation. In fact, there are some mutations which probably you'll not get brain tumors. There are some mutations where you almost always get brain tumors, and then the age of onset of cancers are also different. So I think sequencing is very, very important. That will actually tell us not only actually what type of mutation, what it is, but also it'll give us other very important subtle features, what we call tumor mutation burden. That means the amount of mutations which we see in the DNA of these tumor cells. So that is something very, very important, because what we know is that if you have very high mutations, then these tumors, tend to actually respond very well to immune checkpoint inhibition. Like, for example, one of the questions was if you have Pol E or Pol D mutations. So there are instances where you get mutations in one of those 4 common BMMRD genes, but there can also be mutations in the Pol D. And that's where you get what we call ultra hypermutant tumors, where they are very, very high mutations in the tumor. And these tumors are known to actually respond very well to immune checkpoint inhibition. Now, there are additional tests which we can do, although again, this depends on either it is at the time of diagnosis or probably later diagnosis or at recurrence, where it can add to it. Like, for example, there is something called tumor infiltration score, or you can actually look at the logic assay, which Liana was talking about, things like that, which can actually add to the information. But in general, sequencing and trying to actually figure out what type of defect, what is the tumor mutation burden, these are some of the important things which will actually help in picking actually some of the treatment protocols. But having said that, I always actually tell you that we are still not sure about what is the best form of treatment. Yes, immune checkpoint inhibition works very well in a lot of these tumors, but generally our suggestion is always make sure that you treat those tumors as per the existing standard of care. Like, for example, if you have a brain tumor and if it's high-grade glioma, right? In general, the opinion is that you go in, try to take out as much as possible. And then, of course, in those instances, radiation is still one of the standard of care. You can't avoid radiation because, it might be difficult for us to actually justify using immune checkpoint inhibition right at the start. Although data is still out there, it's actually coming in. We might change that over a period of time, but still standard of care is actually very important. That is true for even, leukemias, lymphomas. That's true for GI cancers. So in general, wherever there's a tumor, go in, take it out. And of course, screen for it, then sequence it. And then depending on actually all those information, what we get, we make further plans. Starts with standard of care, and then add actually immune checkpoint inhibition, probably at the time of recurrence. So that's where I would actually say, those are the type of information which you need.
Thank you. Did anyone want to add anything to that, or should I maybe move on to the next question? Yeah, okay. Thank you so much for that answer. It was very informative. And okay, looking at the next question, I see here that surveillance is so important for CMMRD kids. However, it only helps find cancers early and it doesn't prevent their formation in the first place. Are there any other treatments or tools that are available to predict or prevent cancer? Maybe Anirban, you can take that one. And then there's just sort of a second part to this question as well about using aspirin for preventing colon cancer, like families have maybe heard about before for Lynch syndrome. And then maybe Venon, you can maybe tackle that.
Yeah, thank you very much for that question. I hope you can hear me. So the question about early detection, Liana alluded to you sometimes about that. So we do have novel tools where we are using, we talked about CSF, but we also plan to look at blood to see whether we can pick up some of the early changes that can help us detect tumor early, because surveillance using MRI is great, but it's not perfect. And we do feel that we do have to develop complementary tools to improve our understanding, because early diagnosis and early treatment does have a huge impact on our patients. So that was number one. The prevention question is more tricky and we are all learning, but we do have some evidence that from the Lynch word, especially that vaccines even may work in some patients for preventive aspects. That is something that we as a group plan to look into, and we do have a grant that we hope to use in the next several years to go down that path. So exciting times from the prevention bit, but realistically, probably not today. That's something that we have in hand. And for the aspirin question, I would defer to Dr. Venon. Thank you.
It's actually a very, very interesting question. In fact, I was not only surprised, but I actually appreciate that question. Because yes, there is some data to suggest that aspirin probably helps in the prevention of cancers, especially in Lynch. But what we have to actually keep in mind is Lynch, the tumor incidence, as well as actually the what we call actually the penetrance is very, very variable. So this is why there is a possibility that, yes, it might really help in certain situations, whereas there's a possibility that probably the patient didn't have actually an incidence of cancer over a long period of time. So this is why it's difficult to correlate. Although there are some studies which very clearly say that, yes, starting aspirin in Lynch helps. Whereas in CMMRD, We still don't have any data for that. So at this time, probably I would suggest that it's still sort of a research question. Probably, there is a possibility that we might have to go back and look at the biology of the tumor to see whether there can be any correlation in starting anti-inflammatories like aspirin. But as of now, there is not sufficient data to suggest that, by giving aspirin, you can actually prevent formation of tumors in CMMRD.
Thank you both so much for that. We're getting a ton of questions coming into the Q&A as well. So I'm actually going to try and take a few from there as well. So one of the questions that we're getting is about, when patients were initially diagnosed with CMMRD, they're being told that it's very rare. But, as families, some of them may believe it's just actually very rarely diagnosed. Does our team believe that with increased screening, there will be more correlation found between children's cancers and genetic conditions such as CMMRD? Does someone from our team want to grab that one? Dr. Tabori?
Maybe I'll take that one. And I texted that, but maybe we should have this. So we always say that we see the tip of the iceberg, isn't it? That's exactly the question. It's so true, isn't it? So what happens in the past, we just use family history, and Bailey knows that, and also clinical manifestations, as Ayse said. And we found some patients with cancer predisposition, but many of them we actually missed. And now we found that the germline mutations are responsible to many of childhood cancers. And we include that, what we call AYA, adolescents and young adults, at least until age 40. In the last time we discussed, we talked about a tool called Logic, which is a functional genomic assay that is very cheap, can be done in almost all laboratories in the world. And the beauty about it is that can be used on saliva and everything, but also paraffin blocks. So now we are screening together with large centers in North America, thousands of childhood cancers, and also adolescents and young adults. And for me, it's, oh my God. In brain tumors, we find that 5 to 10% of gliomas are actually mismatch repair deficient. Nobody knew that before because most of the patients are not CMRD. They are Lynch. We just missed them. And the treatment is so different. So the answer to your question is that we see the tip of the iceberg. We think it's about 5% based on the data that we are collecting now. And maybe in the future, one of the things to do for every childhood cancer, as Vanan said, will be just to use this cheap tool to test for mismatch repair deficiency. A, because you treat the patient differently. And second, because then you can do the cascade for the whole family that maybe Bailey will talk more about.
Can I quickly add on that?
Yep.
Yeah, I have been a very strong advocate for actually screening for BMMRD for every childhood cancer patient. I keep telling that, like what we do in today's brain tumors, we do BRAF testing for every low-grade glioma. So people don't even ask for it because it's now routine. We know that that's what it is. So in my opinion, I think, especially in patients where you have strong suspicion or even without suspicion, because some of these patients manifest very differently. So my suggestion, in fact, again, it all depends on, how your local team works. So I would strongly recommend that, we need to be screening this because as Uri said, there are now easy and cheap ways to do this. Of course, I'm still hoping that the Logic assay will become clinically clear approved and then it will be widely available. But until then, immunohistochemistry is just a routine screening. And hopefully we'll be able to actually get good answers from that.
Thank you. And I think part of, putting on sessions like this, hopefully to increase awareness around it so that we can start implementing these as standard of care. People have heard of what mismatch repair deficiency is now. They know to screen for it in tumors. So I think things are changing, but of course, slowly. And, we're obviously very excited about developing new tools and going through the process of getting them CLIA approved clinically so that they can be used in centers all over the world. Definitely. So, All right, I'm going to go to the next question. As you know, in Ayse's talk, she talked about cafe lait macules, which are often found on CMMRD patients, but of course not exclusively. We see them on patients that are healthy or patients with other cancer syndromes. Parents may worry that their children have CMMRD if they see what look like cafe lait macules on their child's skin. There are relatively few resource guides that exist for families regarding this. And so maybe I'll have Bailey take this question. Can you please explain how CMMRD is diagnosed and what to look for? And how important are cafe lait macules for diagnosis?
Thank you. Yeah, it's a great question. I think it's a bit, and we've talked about this, maybe two parts, because as Ori just mentioned, as we've been talking about, we have now these tools like the logic, these functional genomic assays that are more available, or and hopefully in the very near future are clinically available, but are available now during research. So it's not to say that the cafe laits aren't important, but if we can get more of a yes or no answer from these assays, we want to. So if our suspicion is even low, we would maybe want to use them. If it's high, definitely use them. But sometimes, of course, people, if they're reading about this, don't know. So we have had some families come to us, kind of like two parts, some children that have cancer and some cafe lait macules. So that's definitely something we, red flags, raise suspicions for. But we have had some families where things don't necessarily fit exactly. So for example, I could think of a family where a parent had Lynch syndrome and the child had cafe lait macules, but there was no pediatric cancer. So I think in those situations, we can, think back to things like cafe lait macules and what else would you need for the diagnosis. So just thinking, we don't have, in 2014, Katarina Wimmer made surveillance like criteria, a point system. So that's a family where we could use it. And if they don't meet the 3 points, which they might not without a childhood cancer, that's helpful. So educating families about that. So I think it's important to know about the cafe lait macules, but I don't think they're the be all and end all, especially if we have other ways, because we know that they can present without them. So we don't want to only use them, but they're definitely a big part of the picture, especially as we're still, deciding who's going to have these tests that are available now. So as the next step.
Thank you, Bailey. That was really great. Is there anything else to add, or I can move on to the next question? I think I'll move on. So this has been touched on a little bit already, but I'll expand on it a little bit. How does my child's doctor and the International Replication Repair Deficiency Consortium work together, especially in cases outside of Toronto? So I'll maybe take the first part of this. We've touched on it a little bit as well already, but if you know of a patient or you have a patient that has a mismatch repair deficient cancer or germline predisposition and you want to work with us, sometimes we have families that approach us independently from their healthcare team. Sometimes the healthcare team knows about us or has researched us and found us and contacts us to help consult on patient care. So both of those are ways in which we are maybe first introduced to families. And at that point, we then do what we call like a clinical consult. We'll review the case, we'll help answer any questions that the healthcare team has. And if the family does want to register to the consortium, we can get material like blood, spinal fluid, tumor material, saliva. These sorts of tissues can be sent here for additional testing. It'll all depend on the consult, what we feel we need to do, what testing we feel we need to run. But then we can revert back to the healthcare team locally at that center. We can advise them on things like treatment. We can tell them the results of our work, which they can then convey to you as the patient. We don't necessarily have all the patients that are registered to the consortium come to Toronto to the Hospital for Sick Children for treatment, but we work with the local healthcare teams. And this is something we have done multiple times now with Dr. Van En, who's on our panel. So if there's anything you maybe want to add to that with respect to your experience working with us, that'd be great.
Absolutely. So right at the upfront, in fact, I should say we have a fantastic team. So kudos to all the folks who work there, including Vanessa, Lucy, Ayse, Uri, of course, in fact, Cynthia. We just work on a regular basis, although there is some 4,000, 5,000 kilometer distance, but I can still tell you that we work on almost like an everyday basis, in fact. So one thing I have to actually stress the importance is, even before actually making all this, the most important thing is suspicion and making a diagnosis. That is where actually everything starts. Because once you are suspicious of this patient and then actually make a diagnosis, then of course what Vanessa said absolutely holds good. Single most important thing is make sure that you contact folks at SickKids, especially the consortium, and enroll the patient, in fact. Now, I know that different institutes work differently because, and again, outside the country, it works differently. But in general, there are some legalities and some procedures where, there is data transfer agreement, material transfer agreement, and all that. Sometimes it takes a long time.
Yeah.
But even before we do all that, I think it's important that we get expertise in terms of actually how do you diagnose, how do you screen, what are at least the initial types of treatments you start with, how do you actually follow these patients, especially surveillance protocols for their families. Those are the type of things which you can actually get immediately, even before you enroll the patient on the consortium. But it's very, very important for us. Again, I'm pitching in for the whole consortium, is that we enroll as many patients as possible, because that is what gives us data like what Ayse showed today, which actually helps us make decisions regarding how we treat, how we actually monitor this patient. That's how it helps us in the future too. And also more important is, if possible, provide as much tissue as possible, because that could be like what Liana said, including CSF, that could be tumor tissue, that could be even normal tissue. In fact, sometimes we have actually provided just normal skin biopsies to learn about organoid generation and actually trying to see, do research on why certain organs are involved, why certain organs are not involved. So I would strongly encourage everybody who's, on this call, as well as actually you can go and, spread this message out, that it's important for us to actually enroll on the consortium, so that way you will get a lot of benefits in terms of, expertise in treatment and surveillance, but also, you will help us actually to learn more, so that hopefully everybody will learn from this. And so far, in the past 10 years or so, we have had extremely brilliant experience. I can tell you, we actually, one of the earliest patients to be treated on immunotherapy was from our center here. So the consortium has done extremely well, and we are actually very pleased to be a part of that.
Oh, thank you, Dr. Van Ant. We're glad to have you with us as part of the consortium. I just want to, oh, sorry, go ahead.
I just wanted to add something here. From the patient advocate parent perspective, I just want to say it looks very different. We don't, when active treatment is going on, or where then there's an active, you get the diagnosis and you go, it's not like the consortium can immediately have a whole call with us, but I know that the consortium is extremely collaborative and want nothing more than to work with the medical team. And so my suggestion as a parent would be to find a doctor within your medical team who's willing to take time to reach out to the consortium and make sure that they're working with them directly. From the hospital perspective, because we're not at SickKids, I would suggest that as a follow-up, you can request in your own hospital, wherever you are. And we've done this at 4 different institutions between both my children. You can request for a parent conference with your medical team. And you can then ask them at that time, have you reached out to SickKids and to the consortium, and what have they said? So this is just my 2 cents, that it does, although we may not see from the outside all of the discussions that have happened between the medical team and the consortium, we know that the consortium is working really hard to collaborate amongst themselves, but also with the medical teams that they are working with across the world. From a parent perspective, we may not see it, but when you're in the hospital, you can ask for your own care conference with your medical team to ensure that you're staying in the loop, including asking them, did the consortium say something? What did they say? And when we were trying to send tissue samples and blood samples to the consortium early on, many, many years ago, it was not very easy to find a medical doctor who was supporting us, but we kept trying, and we finally did find one who supported us, and so we could do it. So sometimes it's straightforward and sometimes it's not, but I think this is where advocacy and being a parent or being a caregiver to someone with it can truly be instrumental in working with the consortium.
Thank you. And maybe I'll just add 1 or 2 more things to that. Van Ann, you touched on the fact that, sometimes there's legal hurdles that need to be overcome in order to get material sent, whether that's material transfer agreements, opening of what's called REBs, IRBs at the sites. And we do have a team here, a really, really strong administrative team who works really hard to do this. We do this all the time. We've done hundreds of these agreements between different centers. And so this is something that we routinely work on and do. And so we can definitely move it along as fast as we can and help with that if that does seem to be a hurdle at your institute. I also want to say that, you know, similar to what you were saying, Parvati, about all the stuff happening behind the scenes, even if we're still in the process of finalizing these legal agreements, we still consult with the clinicians. We're able to speak to them and ask them questions. They're able to ask us questions, and we're able to do our best to advise from afar, even if we haven't had the opportunity yet to actually get tissue and material sent to us. And we always find ways to work with your team. So know that, you know, we're very happy to advise and do a consultation with your physicians. We have weekly rounds where we speak about patients in the consortium. We answer questions from physicians. We'll call them, we'll email them, we'll do Zoom calls with them if they want. So we do this on a weekly basis. We get 3 to 4 new consults every week, as Lucy said. So this is something that we have routinely going on. We discuss new patients that are coming through. We discuss results from patients that are already registered with us. So this really is something that we do all the time that maybe isn't the most obvious to the families that are registered with us. But we do, like you said, speak to the physicians in the background a lot. And they can convey to you what's been said and discussed between us. So thank you so much for bringing that to our attention. All right, I'm going to go to the next question. This is a question around immunotherapy. Is there adequate data yet to suggest that there's superior outcomes for either of the 2 very common immunotherapy agents that we see in pediatrics, so pembrolizumab or nivolumab? So is there any data to suggest one is perhaps better than the other? And do we have a recommended dose for these agents for a pediatric patient population? Maybe Dr. Das, you can take that one since you work with this a lot.
Sure. Thank you, Vanessa. And again, interesting and important question. So as we all say that we work with your medical practitioners, and each institution has its own policy, but biologically speaking, it is very well established biologically that both agents are probably similar. But we also know that what happens biologically and theoretically and what happens in a patient is sometimes different. So sometimes we have patients who have responded to one or not responded to the other and vice versa, but we do not have any specific evidence to say that one is better than the other. But one particular patient may respond to one agent when he has failed the other. That we have seen happen in the consortium, especially if we added other combinatorial therapies. The dose regimens are what usually actually came to us as pediatric oncologists from adults. So nivolumab we give every 2 weeks, pembrolizumab every 3 weeks. But again, we are learning from the adults that because these drugs are unique, they are not dose dependent. Their mechanism in the body is somewhat different. They activate the immune system, as you know. So we may not need to give that 2 weekly or 3 weekly dose for these 2 agents. And now we are in the consortium also telling our physician partners that maybe for nivolumab, you can give a monthly dose similar to pembrolizumab, because that makes life easier for the doctors and the patients, because there is now well-established data from the adult side that the 2 weekly and the monthly regimens are equally efficacious and are not adding up to toxicity. One last point that I want to mention, because we have patients from different parts of the globe and we are always sensitive to that, there are interesting studies going on in those parts of the world where they are trying to use lower doses. And that is a question that we face often because it activates the immune system, whether you need that dose. So we haven't been brave enough to try that in our patients. Sometimes when we had to do that because of toxicity, sometimes we have succeeded, sometimes we have not. But that is something that we probably need to explore together in the future for impacting more patients from across the globe.
Thank you, Dr. Das. So unless there's anything to add, I'm going to go to the next question. So the next question is about cascade testing for parents and relatives who learn that they maybe have Lynch syndrome only after there's a child that's diagnosed with CMMRD. This follow-up testing can be challenging. There's actually a similar question that came into the chat regarding the length of time trying to get testing and whether there's anything that can be done on a national level to help speed this along, or is it different in every province? So maybe that can be touched on a little bit as well. So I'm just wondering if maybe Bailey and Angela, you can comment on your experiences with cascade testing and also provide any insights on how to approach social stigma that may be associated with this sort of cascade testing approach. Bailey, you're muted.
Oh, Angela, you gonna start, or me? Doesn't matter.
Why don't you go ahead and then I'll follow.
Okay. Yeah, no, I'm happy this was asked because we talk about this a lot. So again, a few points that I want to address. Maybe Angela will talk a bit more about the stigma, but just thinking on the experiences with cascade testing, as with CMMRD and other conditions, we are often met with families who want to put all their time and effort, of course, into their child. And we need to remind them, like I said before, it's a process and it's not something that needs to happen immediately, but we need parents who are taking care of their child to be as healthy as they can be. So that's something we just are reminding our families of a lot. So again, if their child has CMMRD, we know that the parents have received a diagnosis of Lynch syndrome. And I think in the moment, it's really easy for the parent to just, push aside their own health and their own screening, for example, because there's so much going on with their child, especially if there's a cancer diagnosis involved too. So I think it's our like for the genetic counselor and the physicians that work with these families to just remind families that like you can be the best parent you can be to your child if you are taking care of your own health. If you are not healthy and well, that's going to obviously have immediate effect. So just reminding them of that. We talk a lot about guilt, and I think it's important to just bring it out to the forefront. A lot of families are thinking about it and they don't want to address it. So we talk a lot about that. That's a very normal emotion, and no matter what we can say to these families, like logically, they understand that it's not their fault. It's emotionally is really hard to ever accept that this is something that, you passed on. So we talk a lot about that. And I think we just try to make it not taboo and normalize it. And again, remind them that, again, so much is happening right now, and it's okay if we don't know everything right now and get the cascade testing done immediately, but to come back to it and not forget about it and not to put it too far in the back burner, just in case we could, of course, diagnose, like, for example, a colon cancer and a parent earlier. And I don't necessarily have the best answer for the process in different provinces. So I know, unfortunately, only Toronto, like Ontario, we can get referrals for testing pushed a bit urgently, like marked as urgent and get done faster. So I don't know how it works, but it might just involve getting in touch with the genetics clinic and explaining the urgency from a referring provider for that cascade testing. And I think Angela's going to talk a bit more about the social stigma that goes along with the cascade testing.
Yeah, thanks, Bailey. So I thought this was a really good question, and my take on the social aspect of it is that one's own awareness is key when responding to stigma, whether that's in your immediate environment or the larger community. And so I'd recommend, again, like engaging with your medical teams as much as possible in sourcing your information directly from the experts involved in your care, because this ultimately grounds your understanding and it allows a step back from sociocultural opinions, many of which can be uninformed, especially when it relates to the stigma or blame of illness. And so the hope here is that by taking this approach, if you wish to do so, you can appropriately respond, advocate, and continue to take action as needed. And so it also hopefully prevents from internalizing displaced blame, like what Bailey talked about, or taking on the biases of others, which is so important when coping with, the demands of a rare diagnosis.
Yeah, I just want to also add, just like from a practical standpoint, what genetic counselors can provide is, especially if so much is going on and a family wants to share with their other family members, but are not able to, or just don't have the maybe the time even, is that letters have been really helpful. So we can provide a letter to the family member just explaining that there's been a diagnosis. You can even keep it private just as a relative in your family with Lynch syndrome or CMMRD or whatever makes most sense. This is the mutation specifically, or the pathogenic variant, and what needs to, and this, to getting a referral to your local genetics clinic. There's great resources on the National Society of Genetic Counselors or the Canadian Association of Genetic Counselors of where to find clinics. So even that can be helpful for families when they're tackling cascade testing.
Thank you both so much.
Maybe I'll want to add and repeat what Bailey said.
Sure.
So in order to take care of a child, so today we're talking about CMMRD, isn't it? In other sessions, we'll talk about others. Mm-hmm. By definition, both parents have Lynch, isn't it? And in a different cascade, all family members have multiple families. So in order to take care of a child, you need to be healthy. And healthy does not always include just genetic knowledge and prevention, and the whole idea of surveillance for Lynch is huge, but also emotional. And I would argue that this is a journey, as we said in the beginning, and maybe even Parvati can repeat what I say. But the idea that Angela and I have actually a patient in the hospital now that we follow when they have active cancer. So in order for parents to really be strong for their child, they need to take care of themselves emotionally, which is a big part of asking for help, using people like Angela, because without that, whatever the medical doctors say, nobody can do. And with respect to healthy parents, once you do the surveillance, once you are aware of things, that's very important. Last and not least, I'm in my family, we have cancer predisposition. The worst thing you want to know that you didn't talk to your brother, sister, cousin, and they developed cancer that you could have prevented. So be careful. I know there are multiple issues to be addressed, but the benefit of finding something early and living a good life is unbelievable once you disseminated the knowledge. So please don't be afraid to do that.
Yeah. Just to add to Ori, I think cultural sensitivity is super important, and depending on where you're from, parents and grandparents may take it the hardest, but at the same time, we started off with siblings because we knew that we could relate to them so much more, and they wanted to help us as well. And so we said, if you want to help us, get yourself tested so we at least know your children are then fine and safe and they don't have to worry about it. And we sort of turned the tables about, like, it would make us feel better to know that your children don't have this, similar to what we have. So I think it's also the narrative. It did take us longer to, inform the grandparents, but then we went more with, it would be really helpful for our child if you got this tested, because, it can give answers, but it can also help us figure out, like, what else can we do for you? But to Uri's point, we had to do this to get our own answers, to figure out, like, why did this happen? And so we it empowered us more than weighed us down, but it's a process and it takes time to get there. But there are amazing folks in this team and in your own teams where you can reach out and get their help in processing it.
Thank you. So looking at the time, I see that we're coming to a close now. I just want to thank the panel so much for your very thoughtful and insightful answers, for the audience, for all their questions that they asked. We may not have gotten to all of them, and if we didn't, I'm so sorry. Please send it to us. We'll be happy to answer it for you later. And I'm just going to throw it over to Lucy to just close the session off.
Yeah, thanks, Vanessa, and agree. Thank you to all of our panelists and for everyone for joining. I just want to reiterate the fact that without any of you, that goes for the physicians and the families and the patients in the audience. Our research and the work we do as a consortium wouldn't be possible. And so it's your involvement in even just events like this that's incredibly important in dictating the future direction of our research and where we choose to focus these educational events and things like that. So I look forward to hearing you, hopefully in terms of feedback. When you close the Zoom, you'll be prompted with a survey. If anyone has ideas for possible collaborations and things like that, you can always reach out to us, replication.repair@sickkids.ca. We have a website as well, replicationrepair.com. And there's information there on the best point of contact for us as well. For those who want to hear the talks again or send the links out to your friends, families, or colleagues, we will try to get that up on our website and send you a link as soon as possible. So with that, thank you so much, everyone, for joining, and enjoy the rest of your day.